جاهزين. دكتور أحمد, are you ready? Okay. Thank you all for keeping with us. Our next speaker is Dr. Ahmed Ghubashi. Dr. Ahmed is Associate Professor of Endodontics, Miss International University, and he is the Head of Continuing Education, Miss International University. غريبة أوي. 2 مصر University أحمد. Okay, Dr. Ahmed is going to talk to us today about surgical or non-surgical retreatment decision matrix. بقول لك ايه يا احمد, الاعلان الاولاني ده طبعا على اي واتش, ابل واتش, ها؟
طبعا.
Please go on.
Okay, thank you, Mr. Chairman. It's really a great pleasure and honor to be here in the 2019 EDSIC. And of course, it's a great pleasure and honor to be with my colleagues and professors, my great mentor, Dr. Ahmed Abdurrahman. It's a pleasure to give my presentation in front of him. And today I'm going to talk about surgical and non-surgical retreatments. Which one is better? Which one is better for the patient, saving masticatory forces, aesthetics? And we will talk about each one of them and how we can avoid going to the last resort, which is the implant placement. As you can see, this is an 85 years old Ed Whitlock. He's a marathon runner. He can run for 4 hours. He's old. As you can see, he's healthy and he's in good shape. So the aim of the medical profession nowadays is to use very miniature armamentarium. They are using microscopes. They are using what is called minimally invasive surgical techniques. They are using minimally invasive instruments, microscopes. They are doing conservative surgeries in order to save the vital structures, muscles, bone, and all of these they are aiming to keep the patient as healthy as they can. They are not only trying to increase the life expectancy of the patients, but they are also trying to keep the patient healthy and in good shape as long as they are living. What about our profession? What about retreatments and non-surgical retreatments? What about the masticatory forces? Are we really saving the teeth for the patient as long as they are living? Are we doing the same thing? Are we conservative? Are we minimally invasive? So let's see. According to the American Association of Endodontics, about 15 million root canal treatments is done every year. And according to this interesting study by Ricoch and his study group, it was found that the success rate of the root canal treatment is about 90%. This means that if we are having 15 million root canal treatments in the United States, we will have, of course, about 1.5 million retreatments. And here in Egypt, we are having the same. We are having root canal treatments done every day. We are having a lot of root canal treatments done, failures, and of course, we will see a lot of retreatments in our clinic, in our practice. So we have to deal with these cases. If you are going to deal with retreatment cases, you have to do what is called decision making. And this is a very important step that you have to take, and you have to put in mind that we should be minimally invasive and we should be also conservative. In order to do this step, the decision making, you have to do it in 2 steps. The first step is to decide whether this tooth needs really retreatment or not. This is the first step, you have to do it. And the second step, that you have to choose which type of retreatment that we are going to do in this case. Again, we are doing the most conservative line of treatment, not the one that we can do. We are choosing the best option that is conserving the tooth structure. So let's do the first step, which is to decide if the case needs retreatment or not. In our clinic, we usually face 3 conditions. 2 asymptomatic conditions. The first one, asymptomatic case. Sorry. So again, the three scenarios we face in our clinics: asymptomatic cases with technical deficiency, the root canal treatment quality is bad. The second condition, or the second scenario we face, is that we have asymptomatic cases with periapical radiolucency, although the quality of the root canal treatment is acceptable. And these two cases, the patient is asymptomatic, he's not seeking any treatment. And the third scenario is that we are having symptomatic cases where the patient are seeking intervention and they are in pain, and we should relieve the pain. So regarding the first scenario, having asymptomatic with technical deficiencies, this quality of the root canal is not acceptable for us. However, if we are having a good seal and the patient is not complaining, we should not retreat these kind of cases. However, we should follow it up. If we are going to change the corona restoration, we will have to do retreatments, and especially this is true if we are going to do bleaching for the case. So, and these recommendations are according to the European Society of Endodontics, published 2006. So, these cases evaluate the corona restoration. If it's good, leave the case as it is. If the quality of the corona restoration is not good, we will have to retreat the case. Second scenario, but 1 second, before going for retreatments, we have to think twice. Why is that? Because sometimes when we go for retreatments, especially in asymptomatic cases, we will have some sort of flare-ups in 20 to 40% of the cases, and we will have maybe we will do some mishaps like perforations, broken files, maybe we'll have ledges, and maybe we complicate the case more than what it is. So if you are going to retreat such a case, you have to talk to the patient, do what is called patient motivation. You should explain every single detail, the scenario, the mishaps that could happen, the flare-up, whether it's pain, swelling, and everything should be informed, the patient should be informed about. The second scenario is asymptomatic cases with periapical radiolucencies. As you can see, related to the palatal root, we are having a radiolucency. However, the patient is not complaining from anything. We have to first know how the case started. We have to go to the history. We have to go to the radiograph if it's available. We can communicate with the clinician who did first the root canal treatment. And then we will evaluate it, and we have to put in mind that the healing process sometimes takes from 1 year to 10 years, with an average of 4 years. So this means that if you are having a bone radiolucency, it may be a stage of healing, and it may be a stage of a disease. So we have to differentiate between both scenarios. If this case is healing, we have to leave it as it is, and we should do nothing to the case. If it's a disease, we will go for retreatments. So not all of the apical radiolucencies are lesions. The third scenario here is symptomatic cases, and this is about 70 or 80% of the cases that we see every day. Symptomatic cases, both of these cases, the patient are complaining from pain on biting. The first one, we can direct our arrow to a periapical radiolucency. However, if we take a look, and again, we can direct also our arrow to a deficient root canal treatment. So we are having technical deficiency, and we are having periapical radiolucency. But when we take a look on the other case here, we will find that we cannot direct our arrow to a deficient quality root canal treatment, or we cannot direct our arrow to periapical bone loss or radiolucency. So why is the patient complaining from pain? And this is very important. We have to know what is called the rationale of treatment. We have to know why is the case is failing. Because if we know why is the case of failing, we will go do our work in order to overcome this cause of failure, and then the case will heal. So before doing any retreatment, you should do what is called the rationale of treatment. We should know what is the cause of failure that we are going to remove in order for the case to heal. So in order to do that, you have to go through clinical examination, radiographic examination, pain history, palpation, percussion, probing depths, and this is very important, 2D examination and 3D examination. One of the most important diagnostic tools nowadays is the 3D radiograph. According to this interesting study by Rodriguez and his study group 2017, he evaluated the effect of using cone beam computed tomography on the decision-making or the strategies or the treatment strategies that the general practitioners will do and endodontists. And a very interesting study, he found that the examiners altered their treatment plan after seeing the CBCT by 50%. In 50% of the cases, the treatment plan was changed after seeing the CBCT scan. So the effect of 3D imaging is very important. Another very interesting result is that the extraction option rose significantly to 20% after viewing the CBCT. This means that about 20% of the cases were recommended for extraction, but the operators did not know that from the 2D. They were able to know that the cases needed extraction from the CBCT scan. And this is very important. So, coming back to the rationale, the case I showed you before, that the patient was complaining from pain and biting. The cause of failure here is that we are having a vertical root fracture related to the palatal root. The quality of the root canal treatment was good, and there was no periapical, there was no bone loss in the periapic radiograph. However, it is very clear in the 3D examination, the vertical root fracture is clear, and on the sagittal view, it's also clear, and on the coronal view, you can see the vertical root fracture. So this case cannot be treated. This case should be scheduled for implant placement. So if you did step number one, know the rationale, why the case needs retreatment, you will have to go to the second step, which is to decide which type of retreatment we will do to the case. What are our treatment options? Our treatment options is like the traffic light. We have non-surgical retreatment. It's green. You can do it. We are minimally invasive. We are not cutting anything from the tooth. We are saving tooth structure. We are conservative. So, of course, it's green. And we have to know that doing non-surgical retreatment, we can do complete removal of infection from the canal. And this is very important. We can do that with non-surgical retreatments. Root resection is not done, so we are conservative. The yellow or the orange light is here, the cases that needs non-surgical retreatment or endo treatment. However, they may need a period of follow-up in order to decide that if the case is accepting the treatment or not. And these cases, it is very important to follow it up. So follow-up is a part of our treatment plan. The last option, the red one, that we have to think properly before going to it is the surgical retreatment. However, sometimes we are obliged to do it. We have to do it when we are having long span bridges, avoiding coronal destruction if we are having custom-made posts and cores. So we will have to avoid doing non-surgical retreatment, and we will jump directly to surgical retreatments. And again, the surgical retreatment, sometimes we don't have time for multiple visits like the non-surgical retreatments, so we go for the surgical retreatment option. Our last resort, of course, is the implant placement. If we can do retreatments, surgical or non-surgical, we will shift to the implant placement. When we offer treatment options to the patient, we have to think in what is called treatment ladder. The treatment ladder, the normal treatment ladder is doing root canal treatment. For 10 days, for 10 years, we can save Sorry, again. The treatment method, if we do root canal treatments, we can save the teeth for 10, 15 years. And if we do root canal retreatment, we can save the teeth again for about 10, 15 more years. And if we do implant placement, we can save the masticatory function and aesthetics for maybe 10, 15 more years. So we are giving the options, multiple options to the patient. However, if we do root canal treatments and then if we find the case is failing after some time and you go directly for the implant placement, you are depriving the patient from a treatment option. And this is not right because we have to save the masticatory function and the aesthetics for the patient as long as they are living, as we mentioned before. These even compromised because of periodontal disease or endodontic problems have a longevity that surpasses by far that of the average implant. And this was confirmed by multiple articles. So what do you think? Can we save a case like this one? You can see that we are having perforation and broken instrument here, periapical bone loss in the CBCT scan. Can we save it? This patient was given the treatment option to, or was scheduled for implant placement. What about this case? What do you think? Perforation here, and broken instrument here, and large periapical lesion as you can see here. The patient was also given the extraction and implant option. What about this one? What do you think? This is a 13 millimeter broken file. Can we save this tooth? Again, the patient was given the option to extract and put an implant. What about this one? Large periapical lesion, as you can see, involving the anterior teeth, and the patient was scheduled for endosurgery. Can we save it without surgery? What do you think about this one too? This case, a very interesting case. The patient was scheduled for extraction of the four posterior teeth and surgical removal of the lesion, surgical reconstruction, then bone augmentation, then implant placement. Is this the right option? Is this the right treatment option that should be given to the patient? We can save buildings, we can renovate it, we can have excellent results, as you can see. What about tissues? What about humans? Of course, Amri Diab will tell us about this, how we can save our bodies. But what about teeth? If you are talking about teeth, this is the case was scheduled for endosurgery. This is a very simple case, in my opinion, and we just have to clean shape the right teeth and do the right thing for the patient. As you can see, the lesion is affecting only the central and lateral incisors. And according to the CBCT, I was evaluating the canine if the lesion is affecting the canine or not. And I was also confirming that the canine should not be treated by vitality testing in order to be sure that the canine is vital and is not affected by the periapical lesion. And here the root canal treatment was done. This is a post-operative, and this is 1 year follow-up, and you can see the amount of bone formation, and there was no need for endosurgery. So it's all about going for the most conservative treatment option first, and then if you want to shift to the least conservative or less conservative, you can go for it. What about this one? This is a molar, upper first molar, with a missed MB2. From the conservation point of view, do we have to retreat all of the canals? Or do we have to retreat only the mesiobuccal canal? We have to evaluate the quality of the filling in the other canals, and this can be done by CBCT scan. And there is a proposal by Nudera in 2005 in 2015, sorry, he mentioned that we can do only selective root retreatment option. We can do that. And it is very successful. So by this technique, you can use the cone beam to evaluate the other canals, and you can find that there is no bone loss related to the palatal root and no bone loss related to the distobuccal root. However, all of the bone loss is related to the mesiobuccal root. That is having the cause of failure. The cause of failure is only in the mesiobuccal root and not in the distobuccal or the palatal root. So if you are going to retreat this case, you will have to address only the mesiobuccal root, MB1 and MB2, and then after filling the case, this is after filling the case, this is after 6 months, and this is after 1 year. So we did not remove the filling from the palatal canal. We did not remove the filling from the distobuccal canal. We are saving this two structure. We are not, maybe when we try to do root canal treatments in the other canal, we do mistakes or mishaps in these other canals. So if you know, and if you are sure from the CBCT scan that the cause of failure is only one root, you will have to go for this root only. Broken instrument management. Every day we see a lot of broken instruments. In order to evaluate the broken instruments, it is very important to examine the case properly, because you have three options. We have leave and obturate option, bypass option, and removal option. Using the CBCT scan, we can evaluate many things: angle of curvature, presence or absence of periapical lesion, canal anatomy, remaining dentine thickness. But in order to detect a broken instrument, it is advised that you have to do a periapic radiograph. Detection of fractured instruments in the 3D imaging cannot be done. As you can see here in this filled canal, we are having a broken instrument here. We can see it because we can evaluate the difference in radiopacity between the two objects. However, when we take a look at the CBCT scan, we cannot differentiate between the two objects. So it is advised that if you are going to do retreatments, the first step you have to do is to take a periapic radiograph. And do not go for panoramic one. Periapic radiograph, because the sensitivity and the resolution of the 2D is higher than the 3D. Then we will go for the 3D in order to evaluate our cases. Leaving an instrument inside the canals is very successful according to this study. This is a systematic review, a high-level study. So what do you think? What shall we do with this case? This case was referred to me to do an endosurgery. Shall we remove it by endosurgery? Shall we remove this instrument? What do you think? From the CBCT scan, we can see that there is no bone loss related to the broken instrument. The patient is having no signs or symptoms, and there is no complaint from it. And as you can see here on this 3D reconstruction, the broken instrument is just resting on the buccal bone. So we don't have to remove it. We just have to follow up the case, and no endosurgery or no resection is needed. If we are going to want to bypass an instrument, this is the most conservative line of treatment. Doing removal of a broken instrument causes destruction of the tooth structure. So if you have a case of broken instrument, you have to go for bypass first, and then if you can't bypass it, you will go for retrieval. This is a case with a broken instrument, and you can see the instrument can be bypassed and treated without destructing the tooth structure. And this is another case. We are having broken instrument is the most apical part of the canal here. And from the CBCT, there was a large lesion, again, that is related to the mesial root, and there was no bone loss related to the distal root. So the decision here was to try to treat only this root, leaving the distal root, and I was able to obturate it. And as you can see, the amount of bone formation from one X-ray to the other, because there was a period between the two steps. And this is the final X-ray after 1 year, and you can see that there is complete bone formation in comparison to this one. So when we talk about bypassing, it's a valid option, conservative option, and we can save our teeth. And this is the case, cone beam before and cone beam after. The amount of bone formation is great. What about removal? Shall we remove the instruments, or is it successful? Yes, it's successful, but when indicated? According to Tiroshi, removing instruments can be done by ultrasonic if the broken instrument is less than 4.5 millimeter. And this is the case I showed you before, broken instrument and perforation. And here the decision was made to repair the perforation and remove the broken instrument. This is the broken instrument. After repairing the perforation, this is the perforation repair here, and this is the canals after removing of the broken instrument, and this is the post-operative. What about holding techniques? Holding techniques are indicated when we are having a broken instrument that is larger than or longer than 4.5 millimeters. So we are having a lot nowadays in the market, like the microforceps, Zoomax microforceps, and this is the one we used in this case. As you can see, the broken instrument is 3 millimeters inside the canal and 10 millimeters outside in the sinus. So I used the Zoomax micro extractor. I exposed only the coronal part of the instrument. Then I used the extractor to pull the instrument out of the canal. And the instrument is out. The patient was a young lady. She didn't want to extract the tooth, so she was very happy that we were able to remove such an instrument. As you can see here, this is the 13 millimeter broken instrument. By the help of this micro extractor, we were able to remove it. And this is the case post-operative X-ray after removing the instrument. Perforation management, again, we are having a lot of cases nowadays. We are having retreatment cases with perforations. The perforation, especially the furcation perforation, is an easy step. You can do it, it's like filling a class 1 cavity, operative cavity. So you just use the MTA carrier, which is like the amalgam carrier, and you put your material inside, and then you will leave it. Of course, this is done after disinfection of the case, and after 1 week, we can see that the MTA is repairing the perforation, and we can do our retreatment then. If you are going to do retreatment, you have to repair the perforation before going to the steps of the retreatment. Perforation repair is all about proper disinfection and good seal. And good seal is offered by using a high quality material like the MTA, and it gives a success rate about 82%. So when we talk about perforation repair, we talk about 8 out of 10 patients we are having successful cases. The 2% that are failing is usually because of the wrong case selection, because sometimes we are having cases like this. These cases cannot be restored. These cases should be scheduled for implant placement. Another case, this case, she was a colleague, she's a dentist, she had the perforation here, and when they were trying to retreat the case, there was a broken instrument was broken, the mesiobuccal, I think, canal, and there was a large radiolucency, as you can see. I did obturate the case, and then I was able to remove the broken instrument, and then we followed up. And as you can see, this is the case after, and this is the case before, and this is the case after. And if you take a look here, I'm magnifying this furcation area, the area related to the perforation repair. You can see the amount of bone formation. And the patient was very happy here because we are having trabecular and bone formation in comparison to this one. And she's my colleague, and she wanted to start putting the corona restoration. Also, these cases, before coming to me, she went to many colleagues, and they all advised her to do an extraction and put an implant. However, she's saving the tooth now, and she's having the tooth. What about this lesion? This is a large lesion, and this now takes us to the second category, where we have some cases that we will have to do root canal treatment, and then we will go for a follow-up period. We have to inform the patient that we are going to do the treatment in two plans. Plan A is we are going to do retreatment, root canal treatment first, and then plan B will be endosurgery if the plan A fails. We have to inform the patient this. And in this case, you can see from the CBCT scan here that all of the central incisors are having two canals. And this is the very good thing of the CBCT scan, that we can know the internal anatomy from the very first beginning. And why am I telling you this information? Because when we tried to we always have a question in our mind. Can we save or can we do root canal treatments in cases with large lesions? According to these studies, no matter how big is the lesion, we can do root canal treatments, and then we will go for follow-up. We can use calcium hydroxide, which can increase our success rate. So in this case, I was able to treat, clean, shape the canals, and then the patient disappeared for about 6 months. And after 6 months, he came back with this. We took an X-ray, and we found that there was not complete, about 30 to 40% bone formation, and the calcium hydroxide was resorbed after doing its job. And as you can see, we did obturating the canals, all of the canals, 2 canals in each central incisor. And after 1 year, we took this periapical X-ray. As you can see, after 12 months, we are having about 50% bone. As we mentioned before, bone formation takes from 1 year to 10 years with an average of 4 years. So this is a successful case, and we have to follow it up and complete following it up. After 1 year, we are having about 50% of bone formation and no need for plan B. And this is 12 months follow-up. What about this case? This case was scheduled for extraction. This case was misdiagnosed as a keratocyst. They thought that there was a keratocyst, and they were going to extract the teeth and reconstruction of the mandible. All I did is that I did a straightforward root canal treatment and retreatment of the case, 1 year follow-up, 2 years follow-up, and you can see the amount of bone formation. And this is the CBCT scan. After 2 years, you can see that we are having now about, again, 50% of bone formation, and the patient is saving his teeth, and he's saving his mandible, and there's no surgery done till this point. What about surgical retreatments? Sometimes we are obliged to do surgical retreatments, as we mentioned before, as cases with custom-made post and cores, long-span bridges, and the success rate of these cases can reach 81%, according to this interesting study by Von Arx. And sometimes this treatment option is the only treatment option. For example, in this tooth, we have a periapical part here that cannot be negotiated. We cannot clean and shape this part of the canal. So I took a CBCT scan to evaluate the case in order to schedule it for surgery. I found that there was a large communication between the lesion and the periapical radiolucency. And so I decided that in order to minimize the time of the surgery, I was going to fill all of the canal with MTA and then take my measurements using the CBCT scan to measure the most apical part, blocked part of the canal. And then I decided that in the surgery, I will just do resection, expose the MTA, and then I will close the case. And this is what I did. By the help of the CBCT scan, I was able to deal with the case. And this is the radiolucency before doing the case and the resection of the distobuccal part. And this is the case after only 3 months. You can see that we are having complete bone formation, only 3 months. And this is the difference between surgical and non-surgical retreatments. In surgical retreatments, the bone formation is faster than the non-surgical retreatments. Okay, in order to complete our decision making, we have to know that we sometimes have vertical fractures. And vertical fractures are diagnosed by 4 characteristic features. The first characteristic feature is having pain on biting or pain on palpation, on percussion or palpation. And this is very easy and very common. But the most characteristic is the deep narrow pocket, the sinus tract, and the halo-type radiolucency. So if we have our cases, retreatment cases especially, we should do what is called probing depth evaluation. We should do that in every case we see. Because sometimes we can, this is an easy case, we can see the vertical fracture, but we have to use our periodontal probe to evaluate the probing depth. As you can see, the probe can go for about 7-8 millimeters inside. However, when we go to the other areas, we will see that we are not having any probing depth. There is no loss of attachment. And this is very characteristic to the vertical root fractures. And in the CBCT scan, we can see that we are having a halo-shaped radiolucency. It's very clear on the sagittal view and in the coronal view, in the axial view too. And this is very characteristic. The halo-type radiolucency or the J-shaped radiolucency is characteristic of vertical root fractures. And a very interesting characteristic feature is the sinus tract. If we have a sinus tract that the level is in the attached gingiva, this is indicating that we are having a case of vertical root fracture. And all of these cases, we cannot save the tooth. We will shift to the last treatment option or our last resort, which is insertion of the implants. So in some cases, we cannot save the teeth. We cannot be conservative. We cannot be minimally invasive. We will go for the implant, which is the last resort. And we have to know that dental implants provide a useful alternative in replacing teeth that cannot be treated with good prognosis. So in order to wrap up decision making, we are depending in 2 steps. Decide if the tooth needs retreatment or not. We have 3 scenarios. Asymptomatic cases with technical deficiency, asymptomatic cases with periapical radiolucency, symptomatic cases. Asymptomatic cases with technical deficiency, we have to evaluate the coronal restoration. If the coronal restoration is good, leave it as it is. Just monitor it. And if we are going to, or if the patient is scheduled, if the patient is scheduled for retreatment, if the patient is scheduled for changing the coronal restoration, we will have to do retreatment. In cases with periapical radiolucency, we have to evaluate, is it a state of healing or is it a state of bone loss, or is it a disease state? If it's healing, we have to leave it as it is. If it's a disease state and the periapical radiolucency is increasing in size, we have to do retreatments. Symptomatic cases, it's the most important thing is knowing the rationale of the retreatment, why we are doing retreatment. We have to know why is the case is failing. We have to know the cause that we are going to remove in order for the case to heal. Step number 2, if we know the cause, we do retreatments. And in order to know the cause, you have to use the most advanced diagnostic tool that we have nowadays, which is 3D imaging. And according to the American Association of Endodontics and according to the joint statement between the American Association of Endodontics and the American Association of Maxillofacial Radiology, published in 2015, they recommended using 3D imaging in non-surgical retreatments, in surgical retreatments, and in the follow-up of outcome. As you can see, on all of the cases, we were following up the cases by CBCT scanning in order to evaluate it. And why is this important? Because if we know that we are having a failing case, we have to extract the tooth directly before losing more bone. And we are, by this way, you are saving the bone for the patient for the implant placement. So it's very important in the cases that we are not sure that it's going to heal, we have to follow it up in order to make sure that the outcome is in our side. The step number 2, as we mentioned before, is to choose between these 3 options, the green one, the orange one, and the red one, and we are trying to avoid the red one unless we have to do it in cases with large, long-span bridges, custom-made posts, as we mentioned before, or if we are lack of time. Implants are the last resort when we can't do any saving of the tooth structure. Thank you. Thank you for listening.
Dr. Ahmed, on behalf of the organizing committee, I'd like to present this certificate.
It's really an honor to be here with you.
Well done.
Thank you. Thank you.
Guys, before ما حدش يمشي يا جماعه، احنا هنعمل زي ديبيت شويه او ديسكشن. اعتقد الدكتور معتز، احنا عندنا الدكتور رائف شريف اعتذر، فاحنا انا ودكتور احمد ودكتور شهاب we're going to discuss some things. if you are interested, please stay with us. تحب تيجي معانا؟ اوكي. خليني اسالكم الاول سؤال. What is success؟ لا can you ممكن نقول لو سمحت؟ ولا علينا نقول لو سمحت عشان الناس تفوق شويه، عشان انا حاسس انهم ابتدوا يناموا. What is success؟ in its general form. السكسس يا جماعه is to attain an obtainable goal. ده الجنرال. بمعنى السكسس بتاعي ممكن يختلف عن السكسس بتاعك. كل واحد ياخد السكسس بتاعه بقى. فهديكم اكزامبل لطيف قوي. في تو جايز، واحد فيهم متفوق جدا فهو رايح الاولمبيكس تو جين، هو الهدف بتاعه الجولدن ميدال. واحد تاني زي ما عندنا في مصر رايح تمثيل مشرف. اوكي، اللي رايح عشان الجولدن ميدال جاب السيلفر. This is for him success or failure. failure. لكن راجل التمثيل مشرف ربنا رفق في صورته وحصل ايه؟ جاب البرونز ميدال. This is success for him or failure. This is success. The same in endo. We have 3 main categories of success. We have clinical success, we have radiographic success, and we have histologic success. If you look at the literature بنقول في السبعينات success 7 to 14% histology. لكن لو بصينا على معظم السكسس اللي احنا بنتكلم عليه it's radiographic success. And actually we have a very good success rate in endo. If you look at conventional root canal treatment, initial treatment, we are talking about how much? 90 to up to 95. Maybe in necrotic cases, apical bronchitis, we have a less success rate, but generally. Okay. Okay, we have a good, if we average is about 90%. For retreatment, we are talking about 80%. For apical microsurgery, you're talking about 90%. Do you think that our success rate in conventional endo had changed over years? Actually, we don't have any evidence in the literature. Do you think that changing your cleaning and mechanical preparation from hand instrumentation to rotary instrumentation improved your success rate? There's no evidence in the literature. So I want you to keep this in mind. Now we are talking more about survival. So in 2005, American Association of Endodontists has introduced a new classification for the outcome. We are talking about functional healing, so we can have more success. Now we have studies showing us success of endo of about 98.5%. 95.8%. And this is something to think about. Dr. Shihab is going to talk to you about a little bit about sizing. Yes.
Does size matter?
Does size matter?
Does size matter as regard healing, as regard adequate disinfection? What do you think? When we acknowledge our root canals, is it better to stay with smaller apical preparations or with larger apical preparations? This is one aspect. Another aspect is the coronal flare. Would you go for smaller tapers or larger tapers? What do you think? What do you actually do? Do we have a consensus? According to the... This is a question I usually ask in the oral exams for the students. How would you decide the size of your finishing file? According to some factors. First of which is the nature of the disease. Is this a vital case or a non-vital case? Of course, logic, if we are having a non-vital case, I would go for larger preparations. This is the second factor, which is the original size of the canal. Am I starting with a small canal or a large canal? A very important aspect that we usually miss is we have to think in our canals in two dimensions, the mesiodistal as well as the buccolingual dimension, because they differ in dimensions. For example, the mesiobuccal root of the upper six, if you look at the diameter, 1 millimeter from the apex, it's like 0.22 millimeters. At the same point, buccolingually, it is 0.4, the double. معنى كده ان فايل 25 هيديك engagement. You will feel that the file is snugly fit in the canal, but this is only from the mesial and the distal walls. Buccolingually, we have space. And this is the rationale for the bypass. This space we are using, yes, for the bypass. So, smaller apical preparations or larger apical preparations. There should be a consensus. And we should go also for the literature, because we have studies and we have SEM photos showing that sizes like 25-6%, we have a large percentage of the root canal untouched. And this is not accepted. The study Dr. Hammo referred to by O.V. Peters in 2003, it was talking about that there are a percentage of like 20 to 40% of the root canal system untouched. This was done on the Pro Taper system with the finishing file F2, 8%. But if there is another study by another one using another size, maybe this percentage would decrease. So this is not something not absolute. What do you think, Dr. Ahmed? What is your favorite finishing size?
Actually, I think it's a flexible strategy. You cannot, it's dependent on the anatomy. If you look at the anatomic study, the modest one says that the apical forming, for example, apical constriction of upper molars or lower molars ranges from 25 to 40. So definitely, if I have an apical constriction size 40, I'm going to stop at 20 or 25. This is a little bit. Depending on irrigation is nice, but there is outcome studies showing that whenever you increase the size, you have more success rate. One study, I think it was a randomized control trial 2012, and they showed that 2 sizes only after the initial file, you have a success rate which is very low. Starting from 3 sizes up to 6 sizes, there was no significant difference, but all of them were significant from the 2 sizes. What?
It's not acceptable because we check the tag back at the apical part. So we have to check the tag back with taper 2 catapertial cones, not taper 6. They do instrumentation with any system rotary file and say they have a tag back with 25 taper 4 or taper 6, which is not acceptable.
My plea here emphasize about something that when you use 4% or 6%, you might have tag back from the middle of the canal, not the apical part. So you get confused that you think that you have a tag back action while the tip is not very much touching in the apical area.
Dr. Ahmed, can I add something?
Okay.
Regarding the apical size, if you are talking about shaping only, it's true that we have to increase the size in order to reach the complete shaping, and by that we're going to remove bacteria. But however, it's not only about shaping, it's also about cleaning, and this is the most important thing. If we go for a minimally invasive sinking, as I was mentioning before, and we have to go for a minimally invasive preparations, we will have, I think, to go for the smallest diameter, especially that we are having a lot of studies now telling us that there was no statistically significant difference between the preparing apical sizes to size 25 or 40. So I think cleaning is a very important aspect that we have to think about.
But let me tell you,
Yes, actually, I agree with you that we are making it's shaping for cleaning. Now, yes. It is not cleaning and shaping, yes. It is shaping for yes. cleaning. And we are emphasizing the role of the irrigant.
Yes.
It is not only the chemical makeup, it is also the
agitation.
Yes, as Dr. Ahmed mentioned, we have to have shear stresses at the walls in order to disrupt the biofilms. Plus, when you activate your solution, and you will see tomorrow Dr. Roland Demore, the lecture will be on the power of the bubble. You have to generate bubbles inside your canal, and when these bubbles explode, they disrupt the biofilm as well. So in order to have adequate shear stresses and adequate bubbling action inside the root canal, you have to create room for this.
Yeah.
You have to create room for this.
Yes.
As I said before, it's depend on the anatomy, what the anatomy you have. But to be frank with, I am totally not agreeing about being very small like that, because I always think about, do we have really that irrigant which is going to penetrate inside the dentin to the area we need? We need more irrigant, more penetrable irrigant. Sodium hypochlorite. This is why they add some surfactant to it sometimes. Viscosity is not very nice. So usually, how much is going to penetrate inside the dentin? And the old saying that we need to enlarge 3 sizes after the initial file. How much is these 3 sizes? What is usually bacteria? How much distance inside dentin bacteria penetrate? Most of the bacteria, how much distance? How many microns?
And how many walls are we touching? How many walls? Maybe we are touching just one side or the other side. And maybe our problem now that we are not having the power enough to introduce the irrigant inside to the most apical part of the canal. And this is, as we all know, in odontist, we all know that we are having devices now, like the gentle wave. It's just starting its way. It is a device that is putting the irrigant inside of the canal, activating the irrigant, and they were able to disinfect the canal. And they published a lot of multi-center studies that they are having 98% success rate. And this is very incredible. Maybe the device is still expensive. Maybe we will go to a stage that we will have no shaping and just cleaning. Maybe it's the future. So I think we are going to this way, but we have to have the tools and the devices that can help us to do the cleaning, which is the aim, and to avoid doing the shaping, which is destructing the tooth structure. I think it's a matter of time.
Was this an independent research? I don't think so.
Okay, it's an idea. Let's make it, it's an idea. We have to respect it. I think about 4 or 5 studies were published nowadays on gentle wave. Maybe I'm talking about the idea.
Yes.
Just the idea. If you are not accepting it, I'm with you, because we still have to wait for a while in order to accept new techniques or new devices. Of course, Dr. Shahab is right.
Ahmed, you don't have enough evidence yet. Even the studies you are talking, most of them, or if not all, the RK series, they don't have a comparative randomized control or something like that to compare it with the other techniques. I'm going to shift for another topic you mentioned.
But I want to wrap up this.
Okay,
بتوسع لغايه كام؟ الناس عايزه تعرف.
ما توسعش خالص. Okay, I told you it depends on anatomy. You cannot really tell.
80% of the canals.
Can you tell me that if I have a young age, which is 14 years old, I'm going to enlarge to 25, it will drop outside the canals. So what is the size? I think you need coronal flare to get your needle up to the 2 millimeters from the working length, your irrigating needle. So this is the size you need to enlarge to, according to the anatomy. It's not, there is no general consensus about this actually.
Yes.
And I think it should be a clinical case per case scenario.
But for the majority of cases,
Majority of cases, I like to go up to 30, 35 till
yes.
now.
طيب قول لهم.
Till now, but
And the taper?
I have a philosophy in this. Of course, in the apical, last apical, few apical millimeters of the canal, most of the canal, maybe some kind of round cross section. So we might have some last 1-2 millimeters. I'm talking about the rest of the canal, because most of the canal will be oval in buccolingual direction. I like to go for 3 sizes after the initial size. How you are going to measure the initial size? I prepare the canal coronal flare, coronal 2/3, and then you can gauge your canal with a manual file, it's 2%. And then I enlarge about 3 sizes. Why 3 sizes? Because 3 sizes, if I'm talking from 20 to 35, it will be about 150 micron. What does that mean? I'm going to remove all dentin, including the bacteria inside, so I can have more room for the irrigant, and I have more penetration inside the dentine for the irrigant. Because most of the bacteria is going to be present between the 50 micron and 150 micron inside the dentine. So when you remove this area, you remove most of the bacteria, and then the irrigant take rest of it. Of course, this applies for if you have a round canal. If you have an oval one, you cannot get this. This is why I like the techniques which I can brush in the canal walls in the oval part of the canal, so I can touch more areas there. Because if you are having like picking motion or something like that, you are going to have much less area touched inside the canal. This is, I don't like the single file systems, because most of them depend on the just picking motion. Large canals, they are not even touched. Yeah, 3D. But I don't like also XP in the shape. Okay, I like to shift for another point, which Ahmed talked about, to do only 1 canal or 2 canals, 1 route if you do preparation. I have some concerns about this. This have been for a few years now in the literature. Some talk about just doing the canal with apical roof. Now مع الكون بيم طبعا بقت العمليه اسهل جدا. ليه؟ في زمان كنا بقى الاكس راي بريبيكال راديوجراف you don't really know if there is a lesion or not, because it's hidden inside the bone, and we need at least 30 to 40% of cortical plate eroded to see the lesion inside. Now with the cone beam, it's much higher accuracy to detect apical radiolucencies. So I can know that this route only have an apical radiolucency, so it have a problem. But the problem that how can I guarantee that microorganisms haven't been there in the other roots but did not reach the apical area yet? So there is a risk, always a risk, that you do one root and leave the others. I believe that if it's easily accessible, it's also case per case scenario. If I have a case, sometimes I do it. A large pulse in the distal canal, to take it kicked out might endanger the tooth structure, and I don't have anything, any reducer on the distal root, I leave it, I don't do it. But if I have no post, I have easy access to all the canals, I'd like to go for safety, to go for cleaning all canals, removing the gutta percha and cleaning. Ahmed might disagree with me, but as I said before, it's a coin. I believe in something, he believes in something. We are friends. He told you that I am his mentor, but he does not have to follow me. He has his own thinking. Always remember that. You have your own mind. As long as you are not breaking biological factors, or you are not doing something non-ethical, the door is open. Someone حد كان عاوز يسأل. If you don't have any bacteria inside this root, there will be no flare-up because it's sterile area. So you are going to just remove the gutta percha and do another gutta percha. Yes. طيب هسألك سيناريو لطيف قوي. العيان ده جالك، انت عندك accessibility, you do all the canals and you did it. And the patient went for a Boston core and a crown. And after 1 year, he came with another root. What are you going to tell him? It's two scenarios. I agree with you. It's very easy. It's tempting for me, even for me, that I just do one root and leave the others don't have anything apical. But I'm thinking about the future. What if happened? Is it easy? It is easy for me to retreat it now. It will take no time. Huh? You take the safety. No, I know, but I take the safety. Is it better to clean all the canals ولا تسيب الكنالز خلينا نتفق مع بعض. انت why this root canal treatment fail؟ احنا الروت كانال مشكلتنا ايه؟ why it fail؟ ليه؟ عشان في مايكرو اورجانيزم. طيب
we should evaluate every case separately by itself. Some cases it's advisable, I think, to remove all of the filling from all of the canals and then re-retreat it. This is according to the quality of the previous root canal. If in this case that I showed you, root canal treatment was done 3 times before, and the last root canal treatment, the quality of the root canal treatment, I know who did the root canal treatment. The root canal treatment that was done before me, I know who did it. So I was having confidence enough to do the retreatment only to just that root. So, but sometimes I will go for this option. So it's a matter, again, of decision making. Sometimes we will go for treating all the canals, and sometimes when we find that the coronal restoration is good and we can find that there is a good bonding over the other canals and there is no source of leakage to the other canals, we will go for this option, which is the selective retreatment option. So again, it's not all, I want to clear that. Not all of the cases I do this kind of technique, but sometimes you can go for this kind of technique. Okay?
Actually, this technique in particular is advocated in certain cases. And it is based on cone beam. You should have a cone beam, you should have your microscope, and mostly it's for teeth which is crowned, which having, for example, post or something like that. So you go selective to the tooth, through the tooth structure, guided by the cone beam, and just retreat this, provided that the other canals. I am talking about certain cases which you have the tooth open already in front of you. It's very easy for you to retreat. And as Ahmed said, it's a select. You have to evaluate every case per se. Sometimes I do like him. I just do the root which need retreatment. And a lot of times, I do all retreatment. I don't want to take the risk. Imagine that, I'm telling you, if you open the tooth and you find evidence of leakage, you find, this black things which you can find over the root canal failing, it's like biofilm. What are you going to do? Are you going to retreat all or you just one? So you have to do your job that you evaluate quite well pre-operatively, and sometimes how much time this root canal treatment has survived. There's so many factors you have to put in your mind while you are making your decision. But for me, if I am hesitating and it's accessible, I go for retreatment of all, because this is a more safe for me than leave other canals untreated or ما تعملهمش روت كانال او ما عدتش روت كانال ويجي العيان بعد سنه او something. If I do the retreatment وجاي بمشكله يبقى هو بحظه كده، اعمل له ايه؟ I will shift to another line of treatment. I told you about the biofilm which is outside the root. You cannot. I always tell my patient, I think conventional root canal treatment, it's a relation between me and your immune system. I clean inside the root canal and your immune system is going to clean outside. If your immune system fails to clean outside, we have to interfere. Of course, we have to interfere surgically. If he is able to clean, this is very good. So remember that sometimes you have biofilm which is present outside and you cannot get it from the root canal system. And this is what we call, the causes of post-treatment endodontic disease. It has been categorized into 4 causes only. Intradental microorganism, extradental infection, foreign body reaction, and true cyst. And now we are talking about true cyst that it might heal by conventional root canal treatment if you remove the etiological factor. So it turns up at the end that it's really, we are revolving around microorganisms, whether it's inside the root canal system cannot control by our means, or outside on the external root surface, which also we are not in conventional root canal treatment able to get rid of it. And remember, at the end, endo is not only conventional treatment. Endo is treatment, retreatment, and surgical endodontics. This is the way. Dr. Shihab, do you want to add something?
Yes, I usually get this question from my students, and my answer was always go for complete retreatment, because this tooth is going to take your signature. You will charge the patient for this retreatment, and you don't want to be embarrassed in the future if there are recurrence of the signs and symptoms. I rarely break this rule. Just أول امبارح I broke it. I had an upper 6 with a crown, and there was a large post in the palatal canal, and the patient did CBCT, and the palatal filling was good, and the apical bone was good. It was intact. So I did not want to go for excessive forces during ultrasonic removal and subject the patient for cracking while removing the post, and I only did the buccal canals. But most of the times, more than 95% of the cases, I do full retreatment.
Okay, thank you guys. Dr. Mu'taz Al-Khawas, my last lecture in this session. Dr. Mu'taz, whenever you are ready, just tell me please. ازيكم؟ نمتوا ولا لسه؟ عموما دكتور معتز هيصحصحكم. احنا هنروح نسمع. طيب عقبال دكتور معتز يخلص الكمبيوتر ممكن